I'm Lars Hansen. I'm here in my capacity as the director of the Becker Friedman Institute, and I'm most pleased to welcome you to this event this evening. The Becker Friedman Institute's mission is to support research that's fundamental to understanding prudent economic policy. I'm reminded of the front end of Milton Friedman's Nobel address arguing for why economics should be embraced as a scientific endeavor. And I quote from his address, "In order to recommend a course of action to achieve an objective, we must first know whether the course of action will in fact promote the objective. Positive scientific knowledge that enables us to predict consequences of possible course of action is clearly a prerequisite for the normative judgment, whether that course of action is desirable. The road to hell is paved with good intentions precisely because of the neglect of this rather obvious point." Since taking the job of initially the Friedman Institute and subsequently the Becker Friedman Institute, I'm continually reminded of this quote and the importance and fundamental scientific underpinning for policy analysis, requiring both a rigorous and thoughtful framework for analysis and supported by the best evidence. To many of my colleagues in economics, especially outside this university, research is judged by how quickly it makes it to printed media without the critical assessment and evaluation needed for scholarship to be truly durable. Today's panel is part of a larger series of events that brings to bear insights from the best scholarship on important policy challenges. We have another such event coming up on June 7th on understanding educational policy choices. Tonight's discussion targets healthcare reform, but aiming to bring to the forefront our current base of scientific knowledge. We've identified top scholars to contribute to a discussion that will be moderated by my colleague and co-chair, Kevin Murphy. Kevin is currently the intellectual leader in the area of price theory, which captures a powerful perspective that has been a mainstay of Chicago economics for many decades. Moreover, Kevin is himself an expert in health economics, as in many other areas. He will acquaint you with the other panelists and will control the discussion. Thank you.
As Lars knows, it's very difficult to control the discussion at Chicago, so I will moderate to some extent. The three panelists tonight, Jim Baumgartner here first, Anoop Milani, and Casey Mulligan, are no strangers to Chicago, all having been trained here. In keeping with the Friedman quote you heard, I think they're going to try to bring some light to a discussion that often lacks a fair amount of light, mostly by trying to really frame the question, I think, in a useful way. And I would add one thing to the Friedman quote. Don't just think about whether a policy will achieve the objective you're interested in, but what other things it'll achieve along the way. And I think, as you'll hear tonight, staying focused on what should be your objective and trying to avoid doing things that don't even help to reach that objective, and also being leery of the other things that might be affected, things beyond maybe the things you were looking immediately at. And I know Friedman was very big on what you might call unintended, although I think George Stigler taught us often intended, unintended consequences. So without further ado, I'll introduce Jim Baumgartner, who's long-term at the CBO, but now with Precision Health Economics, who's going to talk about an area he knows very well, sort of the finance side of health insurance broadly, followed by Anoop Milani, who again is an expert on the healthcare finance side, and Casey Mulligan, a professor here at Chicago, who also is an expert on the finance side. If I made one change to our title, we're not really going to talk a whole lot about reforming healthcare. It's mostly about healthcare finance. But how you finance healthcare really matters, not just for what happens in the healthcare sector, but what happens in the economy as a whole. And hopefully our three panelists will help steer us in that direction. All right, Jim, why don't you start?
Thanks, Kevin. So it's been, I think, over 35 years since I've been in this building. And then on the drive down from the airport, I reckoned that I had spent literally thousands of hours on the A level of this building. And, well, I wish I could say it's good to be back. But that might be a stretch, but seriously, it's good to share this time with you and this panel. So I think there are two maybe the two big issues with healthcare policy. One is the issue of the uninsured. Probably the real issue is getting healthcare for low-income people, but clearly being uninsured is tied to not treating chronic conditions in a timely way, and other financial issues that a family or person can get into. And clearly it's kind of the coin of the realm in DC policy circles. So the uninsured, and I think the other big issue that interacts with that is the high and growing cost of healthcare. And clearly, the more healthcare costs, the more it's going to cost to deal with the uninsured problem. And by the same token, if one's uninsured, higher healthcare costs make it more of a problem for the person involved or the family involved. And healthcare costs have pretty consistently spending per capita healthcare spendings pretty consistently. There were 2 or 3 years that were exceptions, but pretty consistently grown faster than GDP per capita. So spending really is growing in more than real terms. So I have sort of 3 areas. I want to throw out some factoids and then say something or hint at the implications of those facts. And then there'll be issues maybe that we pick up later on in the discussion. So the first area I wanted to look at is the uninsured and the question of who are the uninsured. And a key takeaway, I think, from that is, this is very much an income distribution kind of issue. Back before the Affordable Care Act, so-called Obamacare, right before it passed, that's where these figures are from. So from 2009, over 80% of the non-elderly uninsured. Now remember, I'm going on a tangent here, but people say, we're the only advanced country that does not have a national health care system. Well, we have had one for the elderly and disabled since the mid-1960s. So we do have national health insurance for the elderly and disabled. So the focus of the uninsured is really on the non-elderly population. And if you looked at where the non-elderly uninsured were before Obamacare passed, over 80% of them were below 300% of the poverty level. And if you look within different segments of the income distribution, people below 100% of poverty, this is in 2009, almost 30% of them were uninsured. Between 100 and 200% of poverty, it was about 33% uninsured. Then it drops a lot. As you get to 200 to 400% of poverty, it's like 15%. 15% are uninsured, and above 400% of poverty, under 5% were uninsured. So it really is a problem that was focused at the lower end of the income distribution, and there have been certainly successes on this front in the years following passage of Obamacare, and that if you looked at the uninsurance rate back at the time of passage, well, it depends on what survey you looked at, but, roughly the numbers were like 17, 18, 19% of the non-elderly were uninsured, and those numbers are down above 10, but say 10.5% in 2015, that's figures from. And in numbers, it was like 41 million uninsured in 2013, and down to 28.5 million in 2015. But I think that the takeaway for me from all this is that the uninsured problem at heart is tied to the distribution of income. It is a low income problem, but that's a real problem then for health reform, because then to tackle any of these redistributive types of programs, you end up with a means-tested kind of program that you phase out as people have higher incomes, and that then creates all these work incentive problems get created when you're in that situation. So they're inevitable trade-offs, I'm afraid, that can lead to these work disincentive problems. So that's one thing on the uninsured. Let me move on to a second kind of area and some basic facts, and that is to look at healthcare spending by payer. Now, if you look at spending on the consumption of healthcare, it turns out 21.2%, so over a fifth of spending on healthcare, is done by the Medicare program. So that's a pretty big health plan. That it's over a fifth of the whole system. Turns out Medicaid is about 18%. So together, Medicare plus Medicaid are 40% of healthcare spending comes from those two programs. A little over 35% of spending is done by private health plans. So I think there are a couple takeaways from that. One is that Medicare is important because things that get decided in Medicare do end up spilling over, I think, into the whole system, whether it's a payment mechanism that Medicare uses or whether it's the technologies that Medicare's allowed to be paid for. This ends up spilling over into the rest of the system. And I guess the other big takeaway for me is to think of the subsidies that are involved here. I did a rough calculation once, but in Medicare, it's almost 90% subsidized. That is, the person getting the benefit is only paying, 10 to 12% of the cost of what gets spent. So that's in Medicare. Medicaid obviously is subsidized. And then even private health insurance. So that 35% of spending by private health plans, well, most of those are employment-sponsored plans. And because of the tax exclusion of employer-provided insurance, there's a big subsidy there. If the firm, in essence, it's the equivalent of if a firm spends $1,000 more on health care benefits for a worker, if the worker's marginal tax rate's 30%, it's really only costing $700 in essence to provide those extra benefits. So there's an incentive kind of built in for private health plans to be generous. I think because it's subsidized and because it's very political and the elderly do vote much more than young people, the elderly vote, you've got incentives there to have a system that's generous. And it's not surprising, I think, that we have what some would describe as a bloated system that maybe on the margins is spending on items that might not pass a strict kind of cost benefit if you were paying the costs at the margin. So I think, it's a heavily subsidized system. Medicare's an important player, and ultimately, some kind of health care reform, I think, has to pay attention to the Medicare program. The final area I wanted to look at was just to look at the federal budget going forward. So one thing that's very true is that we do have an aging population, and I'm one of those people. The baby boomers started retiring. The people born in 1946, right after World War II ended, that was the beginning of the baby boom. They became 65 in 2011, and the baby boom lasted for quite a bit more. I'm a 1958 person, which I think was the biggest birth cohort. And, in several years, we'll be hitting age 65. And you've probably all seen figures on how many retired versus working age people there are going to be over the next 20 years compared to what it's been. It's quite an increase. And spending is not only is a big program within the federal budget, Medicare, which is a spending program on the elderly, but the elderly population's growing, and we also ended up although not that there's not some endogeneity here, but we also picked an area where cost growth is high to be a big program in the federal budget. We did a study at CBO on cigarette smoking and the effects of an increased excise tax on cigarettes, and really we were interested in looking at the effects on health and then how that would play out in the federal budget over the long run. So So I'm going to take a different tangent off of that, and that just is one of the figures that we generated out of that study was to just look by age bracket at the healthcare spending on a smoker versus non-smoker. So, from age 25 to 44, 45 to 64, 65 to 74, and then 75 plus healthcare spending, and comparing it for each of those categories, smoker versus non-smoker. And, I often quipped that, a key finding of all this is smoking's bad for you, but getting older is a lot worse. And if you look at the spending, so, there's like 10 to 15% difference between a smoker and non-smoker at the same age. But if you look in these age bracket categories, 45 to 64-year-olds spend twice as much as 25 to 44-year-olds. And then when you get to people 75 plus, their spending is twice as much as the 45 to 64-year group. It really does go up quite a bit with age. And there are going to be a lot more elderly over the next generation. And if you look at projections, and then I'll end on, if you look at the projections and some of the history, it's kind of interesting. So if you look at the major healthcare programs in the federal budget, so that's mainly Medicare and Medicaid, back in 1987, so that was a couple years after I left Chicago, it was 2.1% of GDP, 2.1% of GDP on the major federal health programs. Well, it's now 5.5% of GDP. So it's more than doubled as a fraction of GDP. And 30 years from now, it's projected to be 9.2% of GDP. So it's going to continue to be an issue. And when CBO does, they do this exercise once a year where they project out into the future. If you look at if you kept the spending on the non-entitlement programs, if you kept that spending constant in real terms, so then the big drivers are Social Security, Medicare, and Medicaid. The actual federal budget, federal spending grows from 20.7% of GDP today, and it was actually 21% when I was leaving grad school of GDP. It's been very constant. It's been very constant around 20% of GDP, federal spending, for most of the post-war era. But that's going to jump to 29.4% of GDP. So, almost a third increase over the next 30 years. And that's driven largely by those big three programs, Social Security, Medicare, and Medicaid. So I think the issue's here to stay about health care. So that's good if you're like in the business of studying it or being a consultant in it. But we do have a lot of issues that are going to be still on our plates for a long time to come.
Okay. Thank you, Jim. I'm going to turn now to Anoop, who's going to pick up, I think, on a number of the things that Jim started with. And I think Jim's pointed out that the problem is not getting smaller, it's getting bigger because consumers of healthcare are growing and they're consuming more and more. And Anoop's going to pick up on the insurance side of things.
That's right. Thanks. Okay, so Kevin's right. I'm going to talk a little bit about, pick up on some of the themes that you'll hear in Jim's talk. But before I launch it, I want to kind of give you a preview of what it is that I'm going to say. The first thing should be fairly obvious, which is if you want to figure out, and just before I begin, one of the things I'm going to do is not just talk about the healthcare system generally, but try to talk about some of the policy options that are before us. So there's obviously the Affordable Care Act. It's a choice because we can choose to replace it. An alternative is the American Health Care Act, which is the plan that was passed in the House and is in front of the Senate. I'll think about a little bit about what it looks like, the version that came out of the House. We won't know what comes out of the Senate, but it's maybe a good guess. And then we'll talk about an alternative plan. But in order to understand what the Republican alternative is, you have to kind of know what the ACA is. So I'm going to talk a little bit about that and then tell you a little bit about the American Health Care Act. Then I'm going to tell you something that you probably don't hear a lot, which is the American Health Care Act, and in fact the Affordable Care Act, is not about health. It's about financing. It's not going to really impact health one way or other. And I'll explain why that is. As I said, the main impact of these policies is to affect who pays. And there, when we think about who pays, there's if you're not going to affect the consumption of healthcare, you're not going to, or not affect at least the total level of health, you got to think, well, how do I decide who I should have paid and who I shouldn't have paid? How do I know what is better and worse? One prism that people often use is redistribution or progressive views of welfare. And so I think I'm going to tell you I'm going to try to tell you two things that you might not already think. One is that the ACA was not nearly as progressive as you think, and that the AHCA, which is the Republican alternative, is not as regressive as I think opponents think. And then I'm going to try to propose a better alternative that will either make both sides upset or will make both sides better off. Usually it's the former. Okay. So what does the ACA do? And I'm sorry that this is such a dense graph, but I want to simplify. This is remember, this is like a 1,000-page statute, and you need to simplify it. I'm going to focus on the provisions that are of the Affordable Care Act that expand coverage, provide more people insurance. Okay, there's a bunch of taxes and there's some stuff on cost controls and things like that. I don't think those are first order from a healthcare systems perspective. The Affordable Care Act really acts in three areas, which cover most of the people that are all but the elderly. The first thing that the Affordable Care Act did is it took Medicaid, which is the insurance program or the health care program for the poor, and it expanded it. They said, the ACA said, the Affordable Care Act said that states can expand Medicaid coverage or must expand Medicaid coverage to can expand Medicaid coverage to people that are within 138% of the federal poverty level. What does that mean? That means about $34,000 or less income for a family of four as of 2017. Okay, and 31 states took the ACA's option there. And for those states, the federal government paid under the ACA about 90+% of the expansion. So typically Medicaid is funded jointly by states and the federal government, but the federal government said we'll pay for the expansion. And then also interestingly, the Affordable Care Act cut what are called disproportionate share hospital payments. These are payments that Medicaid and Medicare provide to hospitals to help them with the fact that they are covering poor populations or high burden populations. I'll get back to that in a second. That's a very important component of this. So that's what it did in the Medicaid population. Remember, Medicaid's about the poor. So we've taken care of the poor part of the population. Then we take a look at this group that's not, again, I'm not going to deal with the elderly because I don't think the ACA really does a lot for Medicare in terms of overall coverage. So we're looking at the people that are non-elderly that are remaining after Medicaid. Those are guys that are below 65 and say above 138% of the federal poverty level. Much of those guys are covered by group insurance, which is employer-sponsored insurance. That's about the 35% number that of spending number that Jim was talking about. And then the rest are covered by what is called the non-group or individual market. Those are people that don't have employer-sponsored insurance or don't have jobs and so can't get employer-sponsored insurance. Okay, so what does the ACA do for that? For that group, it does, the most important thing is a price regulation. It says that people that are in that individual market, insurance that's sold to them has to be community rated. That means whoever you are, whether you're healthy or sick, you get virtually the same price. Okay, actually it's not exactly the same price because they can discriminate on age on a 3-to-1 ratio, but for our purposes, let's think about it as same prices for sick and healthy. That's the most important thing. Now here's the thing. If you're a healthy person and you're in the same pool as a sick person, or let's say you're in the same pool as the people that are on this panel and you're in grad school here, you don't want to be there because you're going to pay a lot more than you really would spend outside of the program because you're cross-subsidizing us. Okay? So you guys want to leave the program. That's called adverse selection. And the answer to adverse selection in the Affordable Care Act is something that's unpopular. It's called the individual mandate. You have to buy insurance, otherwise you have to pay a penalty. Not a very big penalty, which is part of the problem, but that was their solution, the individual mandate. There are some other things that are there, but the most important other one that I want to highlight for today is that there are subsidies for people in the individual market so that nobody pays more than 9.5% of their adjusted gross income for health insurance premiums. In fact, for many of those people that are under 400% of the federal poverty level, you're going to pay even less than 9.5%. But it's a subsidy to reduce the price of the health insurance premium. Okay? Now, the cost of these two things, the Medicaid expansion, the non-group expansion, which are the biggest things that the ACA did, is about $700 billion a piece over 10 years. That's really the big ticket items. And if you want to know about the ACA, that pretty much covers it. Okay? Now, there is something else that goes on in the employer market, which is simply there's an employer mandate. It's not super important. All it says is that if an employer doesn't provide insurance, and their workers go to get premium subsidies in the non-group market, there's going to be a fine. That helps finance some of the premium subsidies. That's all that does. And then there's ostensibly a Cadillac tax for really, really expensive employer-sponsored plans. It's it's like the luxury tax in basketball. If you spend too much, we're gonna tax you extra. That's not first order in what was going on, but it's there. Now, what does the AHCA do? As far as we know, it's hard to understand what it does. I'm not even sure everybody that signed it in the House really understands. It may be also true about the ACA. The first thing that the AHCA does is on Medicaid. What it does is basically pulls back on Medicaid. And it does this in the following way. First of all, the expansion states, they're only going to be funded up until 2020 with federal funds, that 90% support. And after that, that's going to end. What will end up happening is that Medicaid will switch to what's called per capita funding. The government will determine in 2016 how much did each state spend per person, and then give the states that amount per person. It's adjusted for inflation. So in 2020, when that happens, it'll be that 2016 spending plus CPI plus 1%. And also, which you often hear from Republicans, they want block grants going back to the states that allows the states to be a little bit more flexible in what they do in their Medicaid program. That's possible after 2020. The other interesting thing is that it does the opposite. The AHCA does the opposite of what the ACA does. It reestablishes those DISH cuts, takes them back, renews DISH funding, and it sets up a state stability fund to pay for high-cost beneficiaries, high-cost patients. Now, what about in the non-group market? It again reverses course. Whereas ACA had community rating, here you're pulling back from community rating. You can now have price on age at a higher ratio, maybe completely flexibly, depending on what the states decide to do. Now, here's the interesting thing. The reason why there was adverse selection was because you told people, the healthy people get priced at the same level as sick people under the ACA, right? So the healthy people want to get out. Now, if you allow the insurance companies to price according to risk, there's a lot less pressure for that because the healthy guys are going to get a lower price than the sick guys. Okay, so you don't really need the individual mandate anymore, and they get rid of the individual mandate. But interestingly, they don't completely get rid of community rating. It just makes community rating a little bit more lax, a little bit more experience rating, but it's not gone completely. How do they solve the problem? They do it with, I think, something that might be even more strict than the individual mandate. They say that if you are an individual that goes off of coverage for 60 days and in the last year, you want to get back on, you have to pay a penalty that's 30% or more of your insurance premium. Now, presumably you left and you came back when you're sick, which means your premiums are going to be high. But then you're going to be penalized 30% if you do that. So what's your incentive? Don't go bare for a little while, okay? It's not worth it. So it's kind of interesting. You know, maybe what the right answer would have been to use this under the ACA, but they didn't. But anyway, so you have this, that's the way they're going to solve for any kind of adverse selection. And the other thing is that there's a restructuring of the premium subsidies. There's a pullback in the premium subsidies. In the short run, they're going to subsidize the young a little bit more so they get back into pools, lowering prices. But in the long run, what's really going to happen is they're going to allow experience rating. Prices are going to rise for sick people, which is typically older people. Older people are going to face higher prices for people below 400% of the federal poverty level, for which this category applies. And the government is going to come in and give those guys a little bit more subsidies. And importantly, it's going to set up a high-risk pool. It's going to say, if you are a high-risk person, we are going to pay the insurance company to have you in their pool. Okay? That make sense? It's just a different way of financing. With the employer-sponsored insurance, you're just going to get rid of the employer mandate. You're going to delay the Cadillac tax until 2025. Okay. Now for the meat of the discussion. So that's a kind of a quick primer on what's going on. I think it's important to know before we jump to conclusions about the AHCA. But what does the AHCA do? I'll tell you what it doesn't do. Probably doesn't affect health outcomes. I know there was a lot of press on this and how many people would die. I don't think that's very realistic. Most studies do show that health insurance increases the amount of health care that people use. But you know what's really surprising? The literature, the best literature, has a hard time showing that health insurance improves health. And we've tried. We've tried really, really hard. You'll find some studies, but if you look carefully at the studies, they usually find effects on small populations for narrow programs and small amounts. And every time there is an impact, you'll often find another set of papers that don't find an impact. And I'm not even talking about publication bias here, right? Which would again bias you away from finding an effect. So let me give you an example of this. So David Card and others found that there was, when you went from without Medicare to Medicaid, without having Medicare to having Medicare. So these are guys that are 64 and they turn 65, become eligible for Medicare. They do experience an improvement in health, about a 1% drop in 7-day mortality. But we have another paper by, again, equally good researchers. This is Amy Finkelstein and Brian McKnight. Find a paper in 2005 saying that when we actually adopted Medicare, which was a much bigger change, we couldn't find significant effects on health. Which is shocking. So you might say, all right, well, let's look at the very best study. Surely they find something. And the answer is no. The Rand health insurance experiment, one of the biggest health insurance experiments ever done, finds that there was no statistically significant effect. There was a mild effect for the poor, but it wasn't statistically significant. For non-poor, there's no effect. It's a 0. The Oregon health insurance experiment, which looks at the impact of expanding Medicaid, which is really relevant for the ACA, shockingly finds no real effects. I mean, there was an improvement in self-reported mental health, which is a little subjective. None of the objective measures really find big effects. There's a recent study using the Behavioral Risk Factor Survey, social survey, and looking at the ACA, and it finds no effect either. So it's kind of disappointing, you would think. Or at least, it's disappointing if your only goal was to change health. But that's not, I don't think, what the impact of that's not really what the ACA was about. I don't think it's what the AHCA about. It's about who pays. But before we go to there, let me tell you why the AHCA and the ACA don't affect health. Okay? Because you might just be puzzled. Why don't these guys find it? Is it that economists aren't very good at figuring out what the impacts are? I don't think that's it. I think what people fail to understand is the United States, before the ACA, had a very good social safety net. Okay? And I think the big part of that social safety net was a statute called EMTALA, which is the Emergency Medical Treatment and Labor Act of 1986. This is one of those things that insiders know, but a lot of people don't know. But you're probably kind of aware of it. You know that if you fall ill, even if you don't have money, you can go to a hospital. You don't even have to go to the emergency department, and you can ask for care, and they have to give it to you before they ask you for money. Okay. Now, what does that really mean? It means that when you fall ill, even if you don't have money, you can get care. Now, you might have a bill later on, but you get care first. So what does that mean? If you fall ill, even if you don't have health insurance, you're going to get care. Okay? You might be stuck with debt, but you're going to get care. Health insurance doesn't change that. It just changes whether or not you're stuck with debt. Does that make sense? So people get the requisite care. That's, I think, what explains why we're not seeing a big health effect. Now, the other reason why you might think that people don't get health insurance doesn't have a big impact is who's actually sick and who's uninsured. Okay, so let's look at before the ACA. And this is a graph that lists, so people on the left side are the most sick. They had the highest expenditure. Think about the bottom line is the one where I put them. And then on the right, you have the ones with the least. So you see a big skew, which is not surprising. People that are very sick have very high expenditures. And then I also, and so that's, you see the amount of the expenditure on the y-axis on the left. But on the y-axis on the right, you see what is the fraction of the population that's paying out of pocket. Okay? That is the people that don't have insurance. And you find that the guys that are the sickest have the lowest out of pocket. They have the highest insured rates. And the guys that are not sick have the lowest insured rates. What does that mean? That means the guys that were uninsured before the ACA were the healthy guys. Of course, if you were really sick, you'd want to get health insurance. You'd want to buy that. So it's not surprising that when you give, after the ACA, you give people more insurance, you're not going to see big health effects because it's the healthy guys that you got insured. One issue that people might have is well, at least you reduce debt, right? So people had less debt once you had the ACA. But it's important to remember that the ACA is not the only thing that reduces debt. We have something called bankruptcy. And bankruptcy helps people write off debt. It was initially intended as a social insurance program, and that's what we see here. In this graph, you see a graph of, for people that are insured versus people uninsured, what is the amount that they were billed by hospitals on the x-axis, and on the y-axis, how much they actually paid. And you'll see guys that are uninsured, actually, after a certain point, don't pay. Debts are not collected, or it's written off in bankruptcy. So again, the debt impacts, we have a system of trying to reduce that. So those aren't the biggest impacts of this program. Really, health insurance is about who pays, okay? And you can see for different programs, it's different groups. And I've divided this up into whether it's federal, state, or private. You find that for private health insurance, it's some combination of federal payment and private payment. The federal payment comes through the tax expenditures that Jim was talking about. For Medicare and Medicaid, that's coming off of the government. Medicare is largely federal. Medicaid is split between federal and state. For out-of-pocket spending, obviously a lot of it comes out of your pocket, but some of it's written off. It's written off and paid for by actually the federal government, because a lot of the written off debt that hospitals have is covered by DISH payments. Or was covered by DISH payments before the ACA, and under the ACA would again be covered by DISH payments. Okay? So now you say, okay, I see there are three basic sources of payments. There's federal, state, and then there's private. Okay? And the question is, how progressive is that? Right? That might be the criteria that you use. This is a figure that shows, the ones on the left show you basically by income quintile, what is the tax rate in the federal system? That's the greenish blue. In the state tax system. And then I'm going to talk about what happens in the privately financed. For the publicly financed, you see that the federal government's fairly progressive. So if the federal government ends up with the bill, you're going to have it paid in a fairly progressive manner, just by the fact that because you're taxing the rich to pay for whatever the federal government's paying for. States less so. But what happens in the private sector? In the private sector, it really depends on your pricing. If you have community rating, you're not going to be so progressive. And here's a simple reason. Community rating means the healthy and the sick pay roughly the same price. Well, who are healthy and who are sick? The healthy typically tend to be the young. The sick tend to be the old. As it turns out, older people are richer than younger people. So what that means is you're cross-subsidizing the sick, rich, old people with the healthy, young, poor people. That's not super progressive. It is good to have the healthy pay for the sick, but not if it also means that you're getting the poor to disproportionately pay for the sick, which is what this graph tries to tell you. But before going into details, let me conclude by asking, so now I've told you all this stuff. What does the AHCA really do relative to the ACA? It just shifts around funding, and it's not obvious whether it's more or less progressive than the ACA. Think about Medicaid. What's going on with Medicaid? The AHCA is cutting back government funding for Medicaid. That's pushing people out of Medicaid into the non-group market. Those are the guys that were on the exchanges. So you go from, if you're below 138% of the poverty level, you're being pushed into the non-group market. Okay, so it depends on how the non-group market is being financed. But again, you're certainly moving away from government funding, which is fairly progressive. What about in the non-group market? In the non-group market, you're shifting away from community rating, which is good from a progressive perspective. You don't subsidize things by the healthy or the poor. And you are, that's what you're doing, getting away from community rating. And the AHCA is shifting people towards high-risk pools. So the government is directly paying for the high-risk guys. Now that's, again, shifting towards government funding. So you have two things going on in this middle sector. You have a move away from community rating, which is nicely progressive, and you have the government spending a little bit more, which is also progressive. The only problem is the overall coverage in the non-group market has fallen, so you can't endorse it as fully progressive. What about in the last section, employer-sponsored insurance? I don't think there's much of a change there. You get rid of the mandate, you push more people into the non-group market, and so whatever's going on in the non-group market, that's going to dominate. So I think it's a little bit uncertain. I'm going to end, but I want you to know that there is a better way, and we can talk about it in the Q&A.
So just to summarize what you're saying, so make sure people understand. You're saying, when I think about the uninsured and think about the issue of the uninsured, it's not so much about health care as it is who's paying the bill for the previously uninsured, which was that bill was being paid in some way by the federal government and other transfers. And under the new system, in any of these other systems, you're shifting who pays for it.
Yes, but it's not obvious that you're shifting away from progressive sources of funding.
Okay. All right. Casey, it's not health insurance. It doesn't insure your health.
Correct.
It insures the financial consequences of health.
That's right.
Casey. But it does some other stuff too, right? That's what you're going to tell us.
Yeah, I like the way Jim put it. This is an income distribution is a big issue here. How we split up the economic pie. If you want to change how we split it up, you might affect the size of that pie. And that's a piece I'd like to talk about today. The other part, I guess, that Jim said is dead on. The latest generations of health reform, so I'm not going back to the 60s, are about the non-elderly. And the non-elderly in a modern world, they're the ones who do all the work. Okay, so if you're interfering with how the non-elderly integrate with the economy, you could affect the size of the pie just from that perspective. So I have 3 principles on how to think of these things. The first principle is, if you have free stuff and fairness, you're going to have disincentives. Those are 2 sides of the same coin. I know some people in Washington try to tell you, we can have free stuff and have better incentives. It's not happening, and I'll show you that it didn't happen. Now, one way it can happen is, when we have the free stuff, we'll have more taxes to pay for it, and then I'll have disincentives, and that happens. So that's kind of the European way. But kind of the American way, at least in my lifetime, has been to pay for part of it in another way, which is to exclude people who have jobs or who have incomes from the free stuff. And that doesn't go on the books as a tax, but it has disincentives all the same. I like to kind of think about, okay, how's public policy weighing on the scale as we compare workers to non-workers? In fact, this is one point I would disagree with Jim a little bit. It's not a question of taking benefits away from people on the basis of their income. The ACA does that, but most of what it does is take away benefits or implement penalties or both on the basis of your employment. And that's different. I mean, there are people with low incomes who have jobs and people with high incomes who don't have jobs. And we'll see that what the real heavy weight is on the employment side. So the ACA what it did is threw a bunch of goodies on the scale for people who don't work. And people who do work can't get the goodies. So all the people who work for my employer can't get a lot of that ACA stuff because they work for my employer. And when they stop working for that employer, then they might have a chance of getting something. Now, before the ACA and the AHCA, as was mentioned, we have a policy of giving special tax treatment to the monies that workers spend on their health insurance through their employer. And that was, interestingly, it's one of the rare things I see of this sort. This is a policy that weighed actually on the worker side of the scale because you had to be a worker to get that benefit, and it's a big benefit as has been documented. And one of the things about the AHCA is Republicans, they like that part, but they want to also weigh it on the other side of the scale. They want to say, those opportunities that people at work have, we want people not at work to have that credit opportunity as well. And that's going to weigh on the scale of, relative to what we had before, of discouraging people from working. So as I see it, if you look at the AHCA compared to the ACA, it's going to reduce some disincentives, and I'll show you some of that, but it won't eliminate it. In fact, it won't even eliminate half of this disincentives by my estimates. The ACA put about 5 or 6 points of disincentive. Think of it as an extra tax on your income on top of all the other taxes on your income that you pay. Think of it that way. It was 5 or 6 under the ACA, and the AHCA, if it goes through as it's advertised, would bring it down to about 3. The second principle is that it's a logician might call it the fallacy of the heap, but it's easy to underestimate how the market can react to the incentives that you put out there in public policy. If we take the thing we're talking about today, which is assistance, health assistance or cash assistance for people who are out of work, well, one thing that can happen is people will take longer to get back to work when they leave a job. It'll take longer to get back to work, and that has been studied to death, and it happens. Okay, but that just because it's been studied to death doesn't mean it's the only thing that happens. These things subsidize firing people, and so more people will get fired. That has not been studied a lot, but it doesn't stop it from happening. It subsidized early retirements. Again, it's not studied a lot, but it's still going to happen. It subsidized quitting a job. These are all different ways that the market can react to these kind of subsidies. Even if none of those other things happen, industries are different in their propensity to put people out of work for periods of time. And these subsidies for people out of work are, in effect, subsidies for industries that are cyclical. So another thing that can happen is that cyclical industries will grow at the expense of acyclical industries. So, and according to principle number 2, I'm not even done yet, but we'll pause there. I would disagree with the Noop a little bit, or I would add to what he said. I totally agree when you think about the effect on health. you want to think about what's the baseline, what was there before. I totally agree with that. But I would add that, hey, if you're going to subsidize sick people, you might want to think about if you're going to get more sick people. This tends to happen when you subsidize something, you get more of it. When you tax something, you get less of it. And all these health reforms are trying to do that. And maybe that's part of the reason why the studies can't find the effect that you're supposed to find because, hey, those darn incentives. This is a picture of our labor market. Remember I talked about the people doing the work. It shows, the recession that was not that long ago, and how the amount of labor being done, measured in jobs or hours, fell almost 10% in a short period of time. And then it didn't really come back. It would come back very slowly. And I published a book in 2012 where I looked at some of the federal statutes, the so-called recovery or stimulus statutes, and I said, gee, when you go through program by program, everyone's got a new and clever way to pay people not to work. Maybe what we're going to end up with is people not working if that's what we're going to be doing with our federal policies. And I said, when some of these things expire, and they're supposed to expire, that's when you'll start to see people getting back to work again. Well, after our book was out, so a lot of these things started to expire. In fact, you can see the month when the last ones were paying out. And guess what happened? People started getting back to work. Now, I was just lucky on that one. I understand. By that time, it started to be clear, hey, this Affordable Care Act thing, the court's not going to strike it down and stuff. It's going to come, and we're going to be living with it. And I said, that's got a whole bunch of things that pay people not to work and penalize people for hiring. And so what happened at the end, this picture here, is we started, thanks to the health reform, a new tax on employers. And maybe that would stop our recovery in employment. Guess what happened next? The recovery more or less stopped. And then when we went full on, according to the law, of taxing employers, employment slowed even more. Now maybe Trump gave us a little something at the end. I don't know how you look at those last 4 dots. But the important part is, look at all this recovery that hasn't happened yet. And if we're going to stick with new policies, new compared to what we had 10 or 12 years ago that pay people not to work, we're going to have less people working. Now, what I want to do next is briefly zoom in on this employer penalty part. It's not a trivial thing at all, but it's not the biggest tax in the ACA, but it's the sharpest. It's the one that comes out and shows itself the most easily, as maybe we see even in the time series here. So what I've been working on is a survey of small employers. We did this in March. We just got the results in. And what I did is I classified the employers by the number of full-time employees that they have. And what I've showed you here is how many fringe benefits each employer has on average, other than health insurance. So things like 401k, paid maternity leave, those sort of things. And you can see the bigger firms tend to have more fringe benefits on average. That's not a surprise. That's natural and normal. Maybe there's one little bin there that breaks that pattern, but otherwise the bigger employers tend to have more fringe benefits. The thing I want to show you next is, well, what's the propensity of these employers to have employer health insurance as a benefit? So that's a 0 or 1 for each employer. We're going to look at the average of the zeros and ones, the fraction that offer it, okay? And if things were natural and normal, we ought to see an upward slope here. But we have the ACA. Things are not natural and normal. Here are the results. We see a big hole in the middle here. Now what happened? And magically, that big hole is right between 49 and 50, which is a big number in the ACA about how employers are taxed. The employers above 50, if they don't offer health insurance, they pay a tax. Those below 50 kind of don't. It gets more complicated, but let's think of it that way. And so what's happening here is that those firms who would have been, say, 50, 60, 70, 80, and weren't offering health insurance, maybe because it's not what their employers want to spend their money on, or they're not good at administration, or what it may be, those are the ones who have the incentive to move to the left, to get under that 50. The employers are already offering health coverage, at least if it's compliant by the ACA. They don't have a reason to move down. So what you have is the non-ESI employers, they're the ones who move down. And that's why we see big hole here. That's what I would say, because I think incentives are important. Now, the White House, or at least the previous White House, would probably disagree with me, so we did another thing in the survey. After we asked them how many employees they have, and after we asked them, do they offer health insurance, then we later got into some things about the ACA per se. And then we asked them, hey, you got this ACA, and does that change, how you manage your workforce? Did it cause you to hire more people, or to have them work longer, or what was up with that? And then what I did is I tabulate, so for each firm, you get a 0 or 1. Did you do something to reduce your full-time employment? Either having your existing employees work shorter hours, or when you're hiring new people, just hire part-time people and stop hiring full-time people. So that's what I did, and each dot shows that average. And look at the 3 dots here in our hole. These are, now the middle bin looks to be pretty small. It's just 12 employers there. But on average for those, average of the 81's right there at the green line, above every single one of the other bins. They're all telling me that they changed the way they run their workforce because of the ACA. I could have told you that before I showed you the dots, but now they tell you that. Okay, the last and third principle, the harms from taxes extend far beyond the people who pay them. That comes from Adam Smith. I'm not going to claim any credit for that. And he talked about, hey, look, if there's a place that you're taxing, people are going to run out of that place and run to other places that aren't taxed, and then I'll drive down the return in the so-called untaxed areas. Adam Smith said it has to be right, but we looked at that in the survey as well. And I don't have time to go through all of it, but here's a company who told us, they said, hey, we're a small company. Technically, the law doesn't apply to us. But the law made my competitors get health insurance. They're bigger. So I had to get it too in order to compete. So this is an example where regulation on paper only affects the bigger firms, but the littler firms, they're not even trained in economics. They say, hey, I'm in a market, I have to react as well. So thank you.
All right. It seems like a lot of the policy of the ACA and the AHCA that followed is about dealing with the uninsured. And what is it about? What should we be focused on in dealing with the uninsured, or designing a system that will cover the previously uninsured? And are we likely to do more harm than good? And what is it we're trying to accomplish? That seems to me to be, Anoop would say it's not about health, it's about financing, and Casey would say, well, I got to worry about incentives. So what do you think we should be focused on in healthcare reform? What are the big issues that really need to be solved? I mean, Jim started with talking about how spending's growing a ton and all those other things. What is it about healthcare reform that we should be focused on if it's not about health per se?
Yeah, so I would say the most important thing is figuring out an efficient way for the uninsured to pay for health care that they actually want. And so if you're gonna, if the poor or the uninsured want care, we want to give them capital in the most efficient way possible. If that happens to be insurance, that's great. If it happens to be loans in an efficient credit market, that's fantastic as well. Now, obviously, there's some risk component to it. So, for example, the uncertainty of payments with healthcare, insurance can help with that. But you can smooth it with loans as well, or you can kind of offset some of the really big shocks with loans as well. But you worry then about people having debt and then not being able to repay them. And so we might have a bankruptcy system. So I think what we want to devise is just more efficient capital markets for the poor to get the care that they need and not be wedded to just one approach, which is health insurance.
Casey, what would you say? What should we be thinking about in healthcare reform?
One thing, half joking when I'm in Washington, I suggest, why don't we just give the people the cash? We're spending on their so-called health or health insurance, just give them the cash. And immediately say, no. So there's fundamentally a disagreement between what the lower income people want to spend their money and maybe the rest of us want them to spend their money on. And until you come face to face with that disagreement, I think you're going to have issues. Now, the way I kind of think about it is there some metrics that we can hit? Because we're talking about third-party benefits here. People maybe in Manhattan who aren't poor, who like to think they live in a country where people live a certain way? Is there a way that I can hit the metrics and please them without kind of messing up the marketplace? And I think there are some ways. And ACA actually did some of them, like putting people on Medicaid officially, even though de facto they were on Medicaid already, just they got the card in their pocket now. That's a way to hit metrics and without really changing anything economically.
Jim?
Wow, it's tough. I mean, I ended up just kind of seeing it as a world of trade-offs and a mess no matter what you get into. I mean, I think an argument maybe for not just giving them cash is, again, you're probably going to phase that out at some point, or you're creating even more work disincentives, frankly, because people would rather have cash than health, that you almost don't want to make it too tempting a thing. So you want to provide the health. And I think in the end, you're back to kind of social safety net questions and what's the worst you think other people in your society should get? What's the minimum health care they should have? And, and so if it's health insurance, which I don't think is necessarily the way to go, but if it's health insurance, there is a question, I guess, of, at different levels of income, what do you think is a reasonable amount that a person should be asked to pay? And in a sense, I don't think there ever was that national dialogue. I mean, these plans, you get elected, you have a majority in both houses, and the view is we got about a year or a year and a half to get what we wanted all along, or else time's up. So there's never really a dialogue about what's a reasonable amount that, that people think people should pay.
Why don't we take some audience questions?
What kind of medical care do you get on Medicaid, actually? And is it rift with fraud? And is that a bigger issue? That the fraud has created an antagonism from the middle class. And you get good quality medical care under Medicaid. I mean, you offer it, but what kind of care do you get?
I mean, it is true that, I think it varies in terms of where you are.
I think it can be gamed.
You get. In some places it's good. Some very good hospitals in inner cities have a lot of Medicaid patients. It is true that there's always been issues of getting providers, so I'm really mainly talking about doctors, physicians, and offices, to accept Medicaid patients, because typically the payment's a lot lower than in the private market.
Okay, next question.
On pre-existing conditions, did one deal with it, namely Obamacare, and the other not? I don't think I heard that word mentioned. I heard high-risk pool, so that might be the same thing. But as I understand pre-existing conditions in terms of real pre-existing conditions, major heart, cancer, so forth, small percentage of the population, 5-10%. It would seem like somebody from Chicago would say, address that program to deal with 5-10%, not 100. And then two, from Chicago, on education, we go immediately to school vouchers. I didn't hear specifically healthcare vouchers. I heard cash, but if you're not going to do cash, why not just a healthcare voucher, either for care or for insurance?
Yeah, anybody want to respond, or I could?
Sure. I'd say two things. The first is on pre-existing conditions. As far as I can tell, there's not really a change in the way that the AHCA and ACA address pre-existing conditions. You can't have exclusions based on pre-existing conditions. The main difference is whether or not they can be priced into the insurance plan. Under the AHCA, the Republican plan, it's much more likely to impact the price. I think that's really what people are complaining about. Their premiums are going to rise. It is a small percentage of the population, and so the Republican plan addresses that by having the high-risk pools. It's just a different way of financing that same care. Now, in terms of a voucher plan, actually, because I was running short on time, I didn't mention that, but one of the things I think is the right answer is to get rid of Medicaid, get rid of the insurance exchanges and separate plans, and employer-sponsored care, employer-sponsored insurance, and substitute a form of vouchers where basically we hand out subsidies that enable people to buy what we think are minimally acceptable plans, and we can talk about what those are. And then offer that. And one of the nice things about that is that we can decide who we want to finance and support and who we don't. And if we want to be progressive about it, we can. If we don't have to. The problem right now is we have a bunch of kludges that make it so that we have, we're trying to do redistribution through pricing, which if you take Econ 101 is not always a good idea.
Yeah, two more questions is fine.
Yeah. the we and the they, we decide what they need, because there's a we and the they. That kind of bothered me, but that's beside the point. The real thing is, I expected from the economic consequences of healthcare reform that one of the one of the thing you would discuss is Medicare for all or universal healthcare for whatever. There's various, but and there's more and more people who are supporting that, and it's in the legislation and so on. But you didn't even bother with that one. I guess it doesn't exist. And I'm really disappointed. I would have liked to have heard what you would have to say about the economic consequences of a universal health care or Medicare for all.
Casey actually did talk about it. He mentioned it only in passing when he talked about many other countries that have gone down that road. But Casey, you might want to respond.
Yeah, a number of countries have that. And what they do is they have, instead of having hidden taxes like I talked about today, they have above board taxes. But they're taxes nonetheless. Say the German tax rate's 8% on top of all the other taxes they have. And that, that makes the pie smaller. Yeah.
For who?
I mean, the pie, the whole pie is smaller because of that. Yeah.
Thank you.
Just how bad or how good, maybe not, but how unacceptable or maybe how unsustainable were American healthcare landscape before ACA? Is there even an objective consensus on that? Thank you.
Well, I think the concern about the growing costs has been there even before the ACA.
And after.
And after.
Yeah.
So that, I think, is an issue. And as I indicated, I think because of the aging of the population, it's going to keep being an issue. I mean, I don't think things are going to fall apart. The issue is how high are people willing to have their taxes be to keep paying for Medicare. It's going to be that there could be sort of an intergenerational conflict in the electorate, I think is a plausible scenario as we go forward. So that problem, I think, was already there. The uninsured issue, I mean, it's, when you start throwing numbers around like 50 million uninsured people, it has a lot of political play. And so I think that issue is still going to be there if the number of uninsured stays high. But I don't know. I don't know if there are any good solutions. And any idea I'd come up with, I'd feel like, well, CBO hasn't scored it yet, so they'll figure out what's wrong with my idea. But
is it? I mean, I don't know. I'm just listening to you guys talk today. It seems to me that access to care and access to insurance are not the same thing. And the biggest thing that seems to change every time we change how we finance it is all the incentives within the healthcare system, which presumably has an effect on spending and things like that. And as Kathy's emphasized, outside the healthcare system, because we and others tie it to income and for good reasons, that it's, we want to take care of health for a wide range of the population. But if we get to thinking about it that way, doesn't that help us design a less harmful system or a better system? I don't know.
I mean, I agree. I think that the thing that gets people really excited is that there are health consequences. And I think that then they start making decisions that are driven only by the health consequences. I think it's actually quite refreshing to find out there are no health consequences. And so now we can think about what is the efficient way to generate the funds for healthcare, and then the efficient way to provide that healthcare, to finance that healthcare. So I find that to be a very positive result. Actually.
And maybe ultimately be able to control the growth and expenditure, which is itself a function of how we finance it as well, presumably.
Yeah, and I think we want to focus on whether or not we're getting good return for our spending. That's really, I think, a first order question, which really gets back to, I think, what you're asking. But that's not the debate in the ACA or the HCA. That's a different debate that we still need to have in the healthcare system.
Maybe we should be having more of that debate and less of this. I mean, not that this debate's unimportant, but this debate seems to have its biggest effects on the incentives that people have both in healthcare and outside of healthcare. Not so much about healthcare per se. With that in mind, why don't we stop there, and thank you all for attending. Hopefully we've touched on some important issues.